there's an even more basic issue out there than payment mechanisms. That is whether or not we're going to have any money at all with which to fund some of these programs. And we have, did you ever hear of the fiscal cliff? If I hear that phrase once more, I'm going to, you know, there's an effort underfoot in Washington as we speak to say that where some people in the Congress are actually taking the position that what we need to do in this country is to protect those people at the very top of the economic ladder while throwing people at the bottom, as I was saying earlier, as Martha Griffith said 45 years ago, to the side of the road. And so people who depend on Medicare, people who depend on Medicaid, people who depend on human services programs are in more danger now than they've been in some time because of this, what I consider to be a nonsensical debate that's going on in the Congress currently. And hopefully there will be a decision to not do that. There will be a decision to say that the results of the election were pretty clear, and that's that poor people and people who are vulnerable and need to be protected by the government need to be just that. They need to be protected by the government. At the same time that's going on, we have a reversal of economic fortune, at least on a modest scale here in the Commonwealth. And so there's another round of 9C cuts, which are falling on, again, they're falling disproportionately on poor people and elderly people and children and so on. And so it's a very, very tough time for health and human services. And we're just so fortunate in this state to have JudyAnn Bigby as the Secretary of Health and Human Services. She's been in that post since 2007, and the first 2 years were pretty good economically and from a budget perspective. We were still rolling along pretty well, and the budgets were pretty good. Since the meltdown, things haven't been so good, and she has been there day in and day out fighting for the programs that everybody in this room spends 24/7 working for, and not just the programs, for the people who depend on those programs. And I know she's going to continue to do that during this tough period that's ahead of her and ahead of all of us. So please welcome our Secretary of Health and Human Services for the Commonwealth, Dr. JudyAnn Bigby.
Good morning, everyone, and thank you, Phil, for that introduction and for highlighting the news that came from for Beacon Hill yesterday about our 9C cuts. But I'm also, I want to thank the Massachusetts Medicaid Policy Institute and the Blue Cross Foundation for asking me to be here today to address this group. And I'm sorry I didn't get to hear all of the presentations from our colleagues from outside of Massachusetts, but I'm very energized by the innovations that are going on all over the country. And I think there is a lesson to be taken away from the work that states are doing. States recognize that healthcare spending is a big issue for state budgets. And they are approaching this in the right way, rather than saying, well, let's just cut everything by 10 or 15 or 20%. They're actually looking at ways to bring down spending while, quite frankly, improving care delivery. So I think those who are talking about what we need to do to get beyond the gridlock in Washington need to pay a lot more attention to states. So now that I've made that statement, I could probably leave. I just want to reiterate how timely and important this conference is, and recognize that while I said I was energized by everything that's going on, it's also a very challenging time. All of us from the different states represented here today want to advance the related goals of improving care, improving health, and containing cost. And I know that we have a lot to learn from each other, but implementing our plans and thoughts and ideas are very challenging. I want to spend a little bit of time today talking about healthcare reform in Massachusetts and talk about not just how we are reforming care, but why we are doing it and why it's so important. Thanks to the leadership of Governor Patrick, we in the Commonwealth, as you know, have made tremendous progress in reforming health care and ensuring that all of our citizens have health insurance coverage. We've expanded coverage to about 98% of the population, including 99.8% of children. My goal is to be able to say one day we've found all 3,000 children in Massachusetts who are uninsured and be able to say we have 100%. But not only have we made sure that people in Massachusetts have insurance coverage when they get sick, but we also know by looking at some of the things that we're tracking and by using the fact that we have near universal coverage to think about, well, what difference does it make? Are people going to be healthier for it? And we do know that people in Massachusetts are healthier for it. More people are accessing primary care. They're receiving prevention services such as cancer screenings. More women are getting early, adequate prenatal care than ever before, in spite of the fact that we spent millions of dollars for more than a decade trying to convince women that they need to get into their appointments. But guess what? When you give them coverage not dependent on whether they're pregnant or not, or whether they're parenting young kids, they found a way into prenatal care when they did become pregnant. We've also started to see that emergency room visits are declining for non-urgent conditions. We estimate that about 150,000 people in Massachusetts, specifically in our Medicaid program, have stopped smoking because we expanded coverage for smoking cessation programs, and there's a tremendous return on investment in that coverage. A recent study by the National Bureau of Economic Research found improvements in physical health, mental health, functional limitations, and joint disorders as a result of increased access to care in Massachusetts. And not surprisingly, women, minorities, and low-income people have experienced the largest improvements in access and the biggest health improvements. And those were the areas where there were the biggest disparities or gaps. So that while I'm proud of the progress that we've made in Massachusetts, and we should all be proud, this could not have been achieved without the partnership, commitment, and collaboration of many people from the business community, from providers, from individuals, and from government, and for those who advocate on behalf of healthcare access in Massachusetts. But for all the success of healthcare reform in Massachusetts, there still is a separate challenge: the rising cost of healthcare, especially the rapid increases in premiums for families and businesses. This is not a problem that is unique to Massachusetts. The United States, as everyone knows, spends more per person on health care than any other country in the world. And Massachusetts pays more per person on health care than any state in the United States. So I guess that makes us the most expensive place in the world. This problem predates and is unrelated to health care reform, and it is unsustainable. These rising costs have a direct effect on consumers, businesses, and government. In Massachusetts, healthcare costs now account for about 40% of the state budget. Yes, I said 40%. This is up from 22% in 1998. As healthcare takes up more and more of the state budget, there's less money for education, transportation, and many other vitally important programs and initiatives, including those that we know as issues that help to address social and environmental determinants of health would help to keep people and communities healthy. Workers are also foregoing increases in wages. At the same time that we recognize healthcare dollars are not always wisely spent. And this brings me again to the fiscal cliff discussions and the amount of money that is on the table to be saved if we wisely implement many of the initiatives that you've heard about today and that others are working on. The Institute of Medicine reports that 30% of every dollar on health care is wasted. This adds up to $750 billion a year. This also means it's about $20 billion a year in Massachusetts. $210 billion was spent on unnecessary services like repeated tests, and $130 billion on inefficiently delivered services. The IOM report also shows that the healthcare system wastes about $75 billion per year on fraud, $55 billion on missed prevention opportunities, and $190 billion on paperwork and unnecessary administrative cost. At the same time that we're paying too much for the wrong kind of care, sometimes we aren't paying enough for the right kind of care. For example, we know that communities with high concentrations of primary care are healthier, yet the primary care system is under strain and undervalued. Part of the problem is the way we pay providers for care. Providers are paid for what they can sell: appointments, procedures, surgeries, and so on. In spite of the tremendous advantages, and Phil didn't mention, I'm actually a primary care physician by training. I practiced at least part-time for about 25 years. And so some of what I'll say about primary care, I have a little interest in, I will admit. In spite of the tremendous advances we've made in understanding how to manage chronic conditions like diabetes to prevent very costly and devastating complications and the importance of prevention, many primary care doctors still see patients by selling their 15-minute appointment slots. That's the way that I practiced when I first started in 1984. And it's encouraging to see the type of progress that is made, at least by understanding what primary care patient-centered medical home should be defined as. But the question still is, even if you're paying for per member per month care management or reforming the way you pay, are primary care providers still seeing people in 15-minute appointments? And how can we move away from that culture? They're not paid for coordinating care, answering phone calls, or managing teams that contribute to care, or doing all the other work that they do to effectively take care of people. The primary care system is overburdened, undercompensated, and unsustainable. It's also fragmented, redundant, and confusing for consumers to navigate. Our system isn't just wasteful, it's sometimes also harmful to our patients. This is the challenge that faces us all. And while the challenge is great, this challenge also presents a great opportunity. Over the past few years, Massachusetts has advanced a number of innovations that support fundamental changes in our payment and delivery systems. Like many of you in the audience, our Mass Health program took the initiative to introduce a multi-payer patient-centered medical home initiative. Through this initiative, the state and commercial payers pay primary care providers to coordinate and manage care. We need to do a lot more to scale that up, and our goal is that every primary care physician would be practicing in a PCMH by 2015. We're also implementing a program to provide integrated care for dual eligibles. This population, as you know, has high rates of disability, and in our population, more than 60% have a behavioral health diagnosis. The innovation will benefit from a delivery system that recognizes that services paid for Medicare and services paid for by Medicaid, including long-term services and supports diversionary services for people with chronic mental illness and substance abuse problems, and independent living supports. And this is a terminology that we're using to signal to people with disabilities that we want them to be able to live independently in the community and work if they can, must be coordinated and delivered across an integrated system. rather than fragmented among different programs. We will pay integrated care organizations a global payment to promote this type of care. It is exactly these types of initiatives that are now supported by the Commonwealth's new comprehensive health reform law. Governor Patrick signed Chapter 224 in August of 2012. This is comprehensive legislation to improve the quality and reduce the cost of the healthcare system. This bill is the latest of many legislative initiatives that Massachusetts has passed in support of health care reform, dating back to bills to expand coverage to the working disabled and to give consumers protection on key insurance standards, such as pre-existing conditions passed in the 1990s, Romney Care passed in 2006, transparency and support for HIT in 2008, and small business health care relief in 2010. Massachusetts, as you can see, has taken an incremental approach to reform. In 2008, we also started building what we call the All-Payer Claims Database, which will have all commercial, Medicaid, and Medicare claims in it. I think that you all recognize the importance of having this type of database available to the state. Chapter 224 builds on these reforms and puts a stake in the ground for a reformed delivery system and to contain the growth of healthcare cost. The bill sets a clear target for healthcare cost containment by holding healthcare cost growth to no more than the economy for both the public and the private sector. The law provides authority to the newly created Health Policy Commission to review the impact of market consolidations and other market activities on cost and require corrective action plans of providers and health plans that impede the state's ability to stay within the confines of the growth benchmark. And for 2013, that benchmark is growth of no more than 3.6%. The law supports investments in health information technology, including our first in the nation statewide health information exchange. The exchange enables healthcare providers and organizations to better integrate primary care and behavioral health, coordinate care, improve safety and quality by enabling the secure exchange of health information from one hospital or provider to another, regardless of the size of that provider and the sophistication of their electronic medical record, regardless of whether or not there are affiliations between those providers, regardless of the location, or, as I said, differences in technology. The law also recognizes that prevention is a critical part of better health and lower cost, and creates a tax credit to encourage businesses to adopt wellness programs, and also provides grant funding for wellness programs and prevention. The law also requires a Health Resource Planning Council to forecast resource needs with the goal of identifying services that are underutilized but high value, so we can identify incentives to promote growth in these services while remaining mindful of the current incentives that encourage overuse of certain technologies and services that are highly compensated. The law also helps to shift our payment methodology from fee-for-service toward payment methodologies that enhance coordinated integrated care. The Health Policy Commission will define a voluntary certification process for accountable care organization and patient-centered medical homes, and create a program of model ACOs that will receive priority in contracting from state programs. The law requires all public players, including our Medicaid program, the Connector Authority, and the state employee health purchaser, to adopt alternative payment methodologies. There are statutorily required targets for Medicaid enrollees to be covered under alternative payment methodologies. The purchasing power of public payers will help spur change in the healthcare system as a whole. There also are requirements that we develop the opportunities for adopting a common set of quality measures, and that we use some standardized definitions about what alternative payment methodologies are. The law also establishes workforce training grants and recognition that we need a different healthcare workforce to support more care outside of institutions, support the implementation and optimization of HIT, and to support more team-based care. Transforming the healthcare payment and delivery system in Massachusetts will not be easy. I'm sure that there will be some resistance to some of these changes, but we are fortunate that we've been able to base our reforms on a collaboration among payers and providers, employers and consumers, and advocates to advance reform. Massachusetts has taken full advantage of many opportunities in the Affordable Care Act. We are home to 5 pioneer ACOs, and other providers are participating in the Medicare Shared Savings initiatives. Commercial payers and providers are taking risk to use alternative payments and hold providers accountable for higher quality care. And they've been able to demonstrate results both on the cost side and the quality side. Existing payment systems are by no means the only culprit standing in the way of sustainable, high-quality healthcare systems. The lessons from past attempts at controlling healthcare cost have taught us that simply tinkering around the edges does not lead to sustainable cost containment and did not do enough to protect consumers and providers. In many instances, those who were in charge took the money and ran, just took it right out of the healthcare system. We must give up the idea that we can create value within the boundaries of the traditional healthcare system or in organizations that are organized the way that they are currently designed. Creating a system where long-term care, chronic disease management, and coordination of multiple conditions is the #1 challenge. High-quality, low-cost health care can only be created by redesigning care from the patient's perspective, not the perspectives of providers and payers. And I will say it again. We must give up the idea that we can create value within the boundaries of traditional healthcare organizations. Existing systems will need to change substantially. This is the challenge we face. As we go forward in Massachusetts to implement Chapter 224, I know there are many, many people in this room who have contributed not only to various aspects of that bill, but who are invested in making sure that we get it right. And getting it right means that we do nothing to jeopardize the access to care that we've been able to achieve through our healthcare reform bill from 2006, that we continue to strive to make sure that we're paying for right care in the right place, and that we recognize that we have outstanding institutions and a history of excellent medical care in Massachusetts, and that we want to continue that, but we want to continue it in the format of what we think is a sustainable healthcare system where we're developing outcomes that show the value and the importance of maintaining health for people and the communities they live in. So I thank you for inviting me here today.